things that you should know in this lecture. I think most of the things have been covered by your pharmacology lectures as well. But there are a couple of things that you have to know an ENT point of view in this area. Right. At the end of this lecture, you should be able to describe the pharmacological basis for the medicine used in rhinitis and sinusitis, discuss the medication used in otitis externa and otitis media, list the drugs used in removal of wax. These are the common things that when you become a GP or a general practitioner or when you become an intern that you should know. List the drugs used in management of vertigo and understanding the pharmacological basis of their usage. So if I tell you in summary, the chronic sinusitis or can, acute sinusitis and chronic sinusitis can be divided into two parts. They are called acute rhinosinusitis or chronic rhinosinusitis. The commonest cause of acute rhinosinusitis that is called as, common cold as well. That is the virus, viral in origin. The commonest viruses are coronavirus, rhinovirus, and influenza and para-influenza viruses are the commonest agents that causes acute viral rhinitis, or rhinosinusitis. The common cold. Their symptoms generally last up to 5 days and paid off by the end of 10 days. So that's what we all get common cold. They're self-limiting and purulent secretions from nose or throat are common and not necessarily indicate of bacterial infections. I assume what you get what I'm talking. Fever and significant facial pain, persisting mucopurulent nasal discharge with worsening symptoms more than 5 days. If your symptoms are persisting more than 5 days, that may be suggestive of a sinusitis and bacterial treatment, antibiotic treatment may be indicated. So, when do you want to prescribe antibiotics for these patients? So the benefit of treating with these patients with antibiotic therapy in pharyngitis, tonsillitis, and non-suppurative otitis media and sinusitis are limited. So we are not prescribing antibiotics much for these symptoms now. So when do you want? We will discuss later. So if you get a patient with acute viral-like sinusitis and rhinosinusitis, you might have to give analgesics. So because patient is in pain, you might have to give antipyretics or paracetamol or something. So because patient has fever, you may use saline irrigation to the nose to get the decongestions. You might prescribe some intranasal glucocorticoids like fluticon, if not mometasone. There are so many nasal sprays. They all are glucocorticoids. Sometimes we prescribe intranasal decongestions, oral, sometimes intranasal. They are like oxymetazoline, cyanometazoline, and sort of things. Use of antihistamines, even though we use, the benefit is doubtful. Mucolytics, again, doubtful benefits. So, corticosteroids, basically, we use as preventive measures as well. The patients who are having recurrent rhinitis episodes, we might use betamethasone nasal drops, budesonide spray, mometasone sprays and all. Why we have to be worried is even though they are locally acting, but if you use them for a longer durations and higher doses, they can be absorbed into systemic system. So in that case, if the conditions like cataract is a possibility, And if you use it for a longer period in pediatric population, they can get growth retardation due to steroids. So that you have to monitor their height uh, if you intend to use steroids for a longer period. So the decongestions generally we use are sodium chloride, normal saline drops. If not, steam inhalation is one other method that we normally use. Other things are sympathomimetics like oxymetazoline, then oxymetazoline, xylometazoline, those type of decongestions actually we use because they causes beta effect of the sympathomimetics that they actually decongest the mucosal blood vessels, or they constrict blood vessels and causes mucosal edema to be reduced. But if you use them for a long period, you can get a condition called rhinitis medicamentosa due to decrease in production of endogenous norepinephrine through a negative feedback mechanism. A beta effect of the sympathomimetics amines that outlast the alpha effect and causes rebound swelling. So when you use them for a longer period, you can get, when you stop it actually, or when you use it for a longer period, your edema or swelling is going to be more in these scenarios. So that you are not supposed to use these type of vasoconstrictors for a longer period. Generally, we advise them to be used for 7 days. Uh, So, what are the symptoms and signs of these type of sinusitis? Obviously, sinus congestion often occurs due to viral infections or allergy. So, they do not require antibiotics. So, generally, just because of your nose is blocked or pain is there, you don't have to use antibiotics. You can give, as I told you, oxymetazoline or cyanometazoline, nasal oral or nasal decongestions. You can have the oral preparations as well. And you should not use more than 7 days. So this is a picture of sinusitis. You can see pus coming out from the sinus. There, drainage. So there are varieties of sinusitis that is called acute rhinosinusitis and chronic rhinosinusitis. So to diagnose sinusitis, you should have symptoms, acute symptoms less than 3 months, that is 12 weeks. They should have one of or more of the symptoms like nasal blockage, obstruction and congestion, and or nasal discharge. So one of those two with facial pain and reduction of smell. I don't think you need to know these classifications precisely, but if you know a patient with facial pain and reduction of sense of smell, nasal blockage, less than 12 weeks, that is acute rhinosinusitis. So in those are for adults. Pediatric population, they have added chronic cough as well, maybe daytime or nighttime. So if you get a patient with chronic cough, that may be an indication of diagnosis of acute rhinosinusitis. So, as I told you initially, if the symptoms are lasting more than less than 5 days, most of the time that is coryza or common cold. If it is more than lasting more than 5 days, and if it is getting worse also, that may be indicative of acute post-viral rhinosinusitis. So these are the features of acute bacterial or post-viral rhinosinusitis. You have the discoloration of the discolored discharge and local pain on the face, fever, elevated blood counts like ESR and CRP, and your symptoms may be a little bit getting better and then worsening. That is because of the secondary bacterial infection. So commonly it is caused by Streptococcus pneumoniae or Haemophilus influenza, Streptococcus pneumoniae or Haemophilus influenza bacteria. Less commonly, it can be due to Moraxella catalysis as well. So these bacterial types you have to know. So this is the diagrammatic representation of acute viral rhinitis in green color. You can see post-viral acute rhinosinusitis in orange in color. So this is the flow chart of management, which I'm not going to discuss. I'll send you across the lecture if you want to see the management. Basically, as a GP, you can initially treat with them with nasal decongestions and topical steroids and symptomatic management. If they have severe symptoms or if they are not getting better within 48 hours, you can refer to a specialist. So obviously that's the management plan for primary care. When they come to us, obviously we have a separate care pathway that we have to follow. So the antibiotics what we can use in these patients commonly are amoxicillin or amoxicillin clavulanic acid. That's the coamoxiclav. So this is the first line of management. If they have allergic to penicillin, you can use either doxycycline, or if not, you can use clindamycin or levofloxacin as the last resort. We try to avoid quinolones because of the TB prevalence in our country. So clarithromycin, azithromycins are generally resistant to Streptococcus pneumoniae, so that usage is limited. So that's rhinitis and rhinosinusitis. We are moving into the acute otitis media, so which is very common among pediatric population, and antibiotic therapy is very less needed because most of the things are viral in origin. There are also coronavirus, influenza and parainfluenza viruses. The bacteria are commonly causing acute otitis media. Again, the Streptococcus pneumoniae, Haemophilus influenza and Moraxella catalysis. Streptococcus Staphylococcus aureus and Streptococcus pyogenes are also features. You can see the eardrum. It's a picture of eardrum. You can see the eardrum is bulging. You can see the pus collection behind the eardrum, red and edematous and dilated blood vessels. These are the features of eardrum on acute otitis media. So initial 2 to 3 days, try to avoid antibiotics for these patients. And then if there is lasting symptoms, you can use the antibiotics for these patients, right? So pneumococcal infection is the most dangerous infection because they can give rise to mastoiditis and otic meningitis. So the key important thing is to diagnose it with the tympanic membrane examination. And children, of course, you have to know they might present with fever, vomiting, irritability, excessive crying, refusal of feed because they might not complain of pain in the ear most of the time. So antibiotic choice, again, amoxicillin and coamoxiclav and supportive medications are important. And if the symptoms are persisting more than 3 months, we consider it as a chronic otitis media, that those patients definitely need to come to a ENT surgeon. So otitis externa, that's the middle ear we talk about. Otitis externa is the outer ear infection. There are several types of outer ear infections that you have to know. The acute localizing outer ear infection is called paruncle or a hair follicle infection. You can symptomatically manage them with local creams and antibiotics and all. They do not need any surgical procedure unless they develop into an abscess. So eczematous otitis externa is basically dermatological condition due to your atopic dermatitis. So you are treating as an allergy. Chronic otitis externa is a condition which happens in swimmers. The people who are going for swimming, they get allergic reaction to chlorine or seawater. They can get irritable, uh, itchy ears, which get with dry, scaly skin. So that we have to avoid going into swimming, and we treat them with symptomatic management with steroid drops and all. So fungal otitis externa is a condition where it's called as otomycosis, where you can get aspergillus or candida into your ear. We treat them with antifungal ear drops, sometimes oral antifungals, and frequent ear suction. Necrotitis otitis externa or malignant otitis externa is a condition which happens in immunocompromised peoples like diabetes and patients with chemotherapy and chronic renal failure. So that condition is not a cancer, but it's quite serious condition. That's why it is called as malignant otitis externa. So they may present with severe pain with scanty discharge. Their pain is in to their symptoms or signs. Not symptoms, basically signs. So their discharge is minimum, but pain, specifically night pain, is extraordinary. And they get mild otorrhea, and they come with lots of granulation tissue formation. They can get involvement of the bone so that they can get osteomyelitis and brain abscess formation, then sinus thrombosis. They can get lower cranial nerve involvements. These type of patients need long term of intravenous antibiotics, sometimes 6 months, up to 6 months, to treat the osteomyelitis. Sorry about that, I got a call. So otitis externa, basically, they come with ear canal pain, itchiness, and fullness and all. When you examine, they have the tragal tenderness. That means when you press around the tragus or pinna, they get pain. And when you examine the ear canal, you can see redness over the ear canals, and sometimes with discharge and eardrum involvement as well. So, why do they get otitis externa? There are some predisposing factors, the canal narrowing, and some people get bone growths over the ear canal, so that is called exostosis, or there is wax inside, foreign body, sebaceous cyst, and then sometimes manipulation by cotton buds, earplugs, hearing aids, instrumentation. There are genetic conditions like eczema, psoriasis, all sort of swimmers, sweating, and usage of materials to clean the ears. So these are the predisposing factors. So we treat them with steroids and antibiotic combination, ear drops, and then we do frequent ear cleaning, and then intravenous antibiotics or oral antibiotics depending on the severity. And if there are complications of otitis externa like osteomyelitis, meningitis, mastoid abscess formation, then what else? You can get dural venous thrombosis, those type of patients, cerebritis, cerebral abscess formation, those type of patients needs definitely specialist care. So drugs what we used in these type of conditions are steroids, antibiotics, and steroid antibiotic combination, antifungal ear drops, and systemic antibiotics. The important thing here, what I want you to know in pharmacological view is the antibiotics like gentamicin, you should not use them for a longer period to years, specifically if they have a eardrum perforation, because they are ototoxic drugs. Like gentamicin, like things are ototoxic, so you are not supposed to use them for as ear drops for a longer period. So the alternative is ciprofloxacin. So wax is a very common condition that we all get. Wax infection is very common among people with narrow ear canals, the people who are cleaning their ears regularly, or the people who are wearing hearing aids and earbuds are very common to get. The problem of earwax is reduction of hearing and frequent infections. So what we use, almond oil, olive oil, sodium bicarbonate, or glycerine as treatment, wax dissolvents, and then we do ear suction or ear syringing to remove wax. So you can use either of these. There are combinations of sodium bicarbonate and glycerin. There are so many commercial brands. I don't want to mention any brands here, but almond oil, olive oil, sodium bicarbonate, and glycerin are the commonest wax dissolvent we are using. Right. So we are moving into the final stage, which is the vertigo. Vertigo is basically rotatory movements of either yourself or surrounding. So there are two varieties of vertigo. One is the peripheral causes, that's peripheral vertigo. Then central causes, that's called central vertigo. So non-peripheral vertigo types are BPPV, Meniere's disease, labyrinthitis, and following ototoxicity and superior canal dehiscencies. I'm not going to discuss about each and every disease here. Then central causes are migrainous vertigo, multiple sclerosis can give rise to vertigo, and the other conditions, as I mentioned here, we are not looking after the central causes, they are the neurologists look after, but peripheral vertigo, of course, our territory. So these are the drugs we generally use for vertigo. Obviously, cinnarizine, that's you can see the action. They are used for peripheral causes of vertigo. And then cinnarizine and dihydrogenate combination. Again, we use it for peripheral causes of vertigo. There are side effects as well. I don't think you have to know all these things, to be honest. But if you know prochlorperazine, no Stemetil or Maxtil, those are the brand names, but that is a prochlorperazine, a potent neuroepileptic. So you should not use these type of medications for a longer period because they can aggravate their uh, other CNS symptoms. They can give rise to other CNS symptoms if you use these type of medications for a longer period because they have an anticholinergic effect. Beta histidine is one of the other most commonly used antivertiginous medicine, which stimulates the H1 and H2 receptors in vestibular nuclei and brain, so that we use it basically for the Meniere's. So you might see beta circuits or beta histidine is being used in long-term basis for all the vertigo across the line, but not all the vertigo actually respond to beta histidine. Beta histidine is mainly for Meniere's disease. But acute vertigo, for symptom management, you can use cinnarizine or prochlorperazine. But for long-term management of Meniere's disease, it's a beta histidine that you have to use. Diazepam sometimes we use as a symptomatic management, but that's not a long-term vertigo management drug. Uh, I don't think you have to know all these details about these drugs in long term or for your exam purpose. But if you know that there's few things about what we use, the usage of antibiotics, you have to be used very precautionary whenever it is necessary only to prevent antibiotic sensitivity issues, resistant issues. Then gentamicin-like eardrops should not be used for a longer period, specifically when there is a eardrum perforation, to prevent ototoxicity related to drugs. Then the medicine that use for vertigo are not cannot be used one medicine for all the vertigos. There are different types of vertigos, so you have to come into a proper diagnosis before treating these patients, because the vertigo may be a sign of central disease as well. Right. I think if you know this is enough for your level, because